Thank you so much, Dr. Maria Sam, for joining us on a very important, not just medically, but psychosocial important topic of seizure disorders.
Thank you for having me.
So, first question I would like to begin, that I get this a lot. Somebody's friend or family member gets diagnosed with seizure and they are surprised, but their body doesn't move. How can it be a seizure disorder? Because in movies and in TV media, the seizure that is well known is where their whole body is thrashing around or they're frothing in the mouth.
Right. So that actually is a common question that families and friends bring up. How can this be a seizure when they don't seem to be jerking, they're not falling down? And it's actually a source of concern for the patients when maybe families and friends do not realize how serious the seizure disorder that they're living day to day with is. And it turns out that if you think about what a seizure is and how it manifests, it should make sense then that not all seizures are going to manifest as jerking of the body. Seizure is in fact just an electrical discharge in the brain that can cause almost anything. It can actually cause just a minor sensation, a minor twitch of a limb, a thought, perhaps a smell, perhaps a taste. But when it becomes very widespread in the brain, then you get to see some of this more commonly thought of as seizure manifestations, which is the motor involvement where you have a lot of jerking, you fall down, you then see the foaming at the mouth and all of those things that follow. Yeah.
Oh wow, so seizures can just manifest as altered taste, sensation, or a smell.
Oh, and they can sometimes be manifested as just someone not being responsive and seemingly being there, eyes are open, they may look like they're listening, but they in fact are not really there.
Okay.
So there's a true alteration of awareness without loss of consciousness, as we say, falling down and jerking and all that.
Okay, that's very good to know. So why such manifestations? Or bottom line, why do seizures happen? What is the mechanism?
Seizures can happen for a number of reasons, and some of the ones that people may be more familiar with are the ones that happen after trauma, maybe after an infection, meningitis, encephalitis. Some of those are very common as causes of seizures. Sometimes seizures are genetic. In other words, there's a change in the genetic code, and maybe even in families where there is no history of seizures, you can get a de novo, as we say, or something new, a new seizure manifestation for that family. But the truth is that sometimes we don't know, and that has to do with the limitation of the tools that we have to investigate. But commonly, for example, in the elderly, we'll see tumors and strokes as the cause of a seizure. In the younger population, you tend to see little kids, you tend to see troubles at birth, the cord wrapped around their neck with some decrease in oxygen can be a cause of seizures in little kids. Sometimes fevers can be the cause of febrile seizures.
Febrile seizures,
right?
Yeah.
So there's many causes, and it's important that we investigate what is the cause, because it's not going to be the same for everyone, and it's not going to be the same for everyone, even in the same population, in the same age group.
Okay, so there are lots of causes of seizures, and every time we are diagnosing somebody with seizure, we should try to investigate the cause to address it.
Right.
So they look scary. Seizures look scary, but somebody can come up to us and ask us this question. Okay, occasionally I smell something, and that's part of their seizure, or the patient is getting periods of unresponsiveness where they're just like lost, they look lost, or even if their body is jerking, they look scary, but are they actually harmful to the brain?
That's a great question. So we know that one seizure, if you try to measure what the damage from that seizure is, you're probably going to have a hard time, just because we don't have a refined set of tools to look at the brain and see that. But we do know that over time, those seizures happening frequently, not being controlled, are going to have a toll. Are going to take a toll on the brain functioning. And you can see it this way. The brain is made to be this incredible computer to help you process information from the outside world and to help you achieve all of what you want to do. If instead it's busy having this sort of distraction, right? The seizure
Right.
activity, you're going to miss out on storing memories, learning new concepts, making the right connections socially, and just relating to your members, other members of society. So you do see a number of patients with trouble with memory, trouble adjusting socially, trouble just keeping a job. So those are things that are not maybe measured in, okay, here's a number, but you see the loss of the ability to produce as a member of society.
Right.
Yeah.
So there are direct damages that seizures can do, like falling down, sustaining injury, and in the period of unresponsiveness, maybe not being able to operate heavy machinery. At the same time, it does have social effects, functional effects, and also just on the long term, if not treated, cognitive effects.
Correct.
Okay. Now, suppose when somebody is having seizure, a bystander, like I'm doing my grocery shopping and somebody starts to have seizure, which is our classic seizure or generalized tonic-clonic seizure, where the whole body is jerking. Other than calling 911, what other things a bystander can do to help that person?
Okay. So there's a few things, and I teach the medical students this all the time, that they need to remember that seizures overall and in general are self-limited
Okay.
events. And that has to do with the characteristics of the brain. An electrical system that gets activated, gets excited, and then it's not able to get excited again until a period of time has passed. So that is going to make those seizures finite in their length most times. So if you remember that, then your job should become one of just looking for safety for that patient.
Safety.
Can you ensure their safety? Can you make sure that if they're on the ground, they're not hitting their head on a hard or sharp instrument? One of the things that I'm always worried about is the well-intentioned bystander that wants to always put something in the mouth of someone having a grand mal seizure. But it's very difficult to actually open the mouth of someone that's having a grand mal seizure. And when someone has a grand mal seizure, you can't really, that person cannot protect their airway. So that instrument, whether it be a spoon, a rolled up towel, a bite guard, is going to become just an object in someone that cannot protect their airway. The object in the mouth of someone that cannot protect their airway. So it's actually more harmful to do that.
Oh.
The best thing to do is to wait till the seizure is over, make sure the patient is safe while it's happening, keep others from actually trying to help, but in a sense actually harming the patient and putting them in harm's way. And then once the seizure is over, roll them on their sides so that all that saliva rolls out of their mouth and not into their lungs, so that they don't aspirate all that saliva and then have things like aspiration pneumonia and all of those things.
Oh, so no, please don't try to put anything in the mouth when somebody's having active seizure. And I saw once they were trying to move the patient while the patient was having seizure on one side. So my question is, should the people try to put the patient on one side to prevent aspiration of the secretion? And if so, which side? Is there a preference?
Right. So I usually make sure that you understand when the seizure is over, it's okay to move the patient. While the seizure is happening, if someone is in the midst of a grand mal seizure, moving them and counteracting some of the forces that the patient himself, not knowingly, is exerting, it can be actually dangerous. This frail ladies, for example, sometimes we'll see them and they're very frail looking, but when they're having a grand mal seizure, they exert this incredible force. And if we oppose that to try to turn them or move them, you can potentially actually break a bone in that patient because you are putting on a force and opposing their force, and all of a sudden there's a weak link somewhere in there, and that's usually the bone. So typically, if someone is having a seizure, the best thing to do is make them safe. Make sure they're not harming themselves any further. If they fell, they already may have a head injury, so you want to make sure that they are as safe as you can make them for the period of time that the seizure is happening. Once that's over, roll them. It doesn't matter what side, just roll them on the side so that all of that saliva goes onto the floor and not into their lungs.
Okay, very good to know. And after the seizure is over, is there a particular side which is preferred to put them on?
Right, so there's no real particular sign. The thing to do after a seizure is over, besides rolling them over, is to look for what I call the ABCs of resuscitation. Basically looking that they're breathing and that they have a pulse. And at that point, you're in the middle of the mall, and this is happening. The next thing you need to do, if no one is with them, you definitely need to call 911 because you don't know the circumstances of the seizure. If they have family, then it'd be nice to actually find out, do they take medicines for seizures? Is this the kind of seizure that you've seen at home? So as to figure out, you know, do we need to call 911? A lot of the patients that have seizures don't want to have a trip to the hospital if they already had the seizures before and they know what's happening. If they actually hit their heads, they probably should be
Evaluated.
just to make sure they haven't you know, had some kind of hemorrhage or some damage to their heads. Yeah.
Now, suppose that person that we found in the grocery store for the first time had the seizure and is taken to the ER, and now they're diagnosed with seizure, who never had a seizure before. What should that person expect in terms of workup, or what is the general expectation in seizure workup as soon as the patient is in the ER, and what questions they should be asking and expecting from the physicians?
Right, so again, the physician in the ER is going to look at that patient and say, you know, what's their age, what are their risk factors for a new onset seizure, and almost immediately they're going to try to get some form of imaging of the brain. They know from experience that depending on the age, you may find a tumor, you may find a hemorrhage, you may find a stroke, a new stroke, but they need to also make sure that there is nothing in there they need to take care of. So if somebody fell with a seizure and now has a subarachnoid hemorrhage, all of a sudden you have a real emergency in your hands. And it may be that the seizure was caused by the subarachnoid hemorrhage that was already before. So it becomes a real important point to tease out which came first and what is the cause. So you're going to expect some kind of neuroimaging. You're going to expect some lab work that's going to be done, because some patients, if they were just seen in the mall, they had a seizure, you don't know if they have had exposure to drugs that have caused this. So you're going to need to do a lot of investigative work, that some of which is going to be pictures, some of which is going to be blood work. The EEG, the electroencephalogram, may or may not be able to be done in the ER depending on the facilities. So typically, those are the three things that you're going to be looking at. If someone comes in with a high fever and they had a seizure, they're going to get a spinal tap, a lumbar puncture, because you're going to be looking for signs of infection affecting the central nervous system.
Okay. So as soon as somebody is coming with a first-time seizure, which never happened before, basically the physician is going to be focusing on what happened due to seizure, like did you break a bone, or did you injure your spine, or what caused the seizure, like if you had a brain bleed or a tumor, so brain imaging will be done for that. If you have infection, then a spinal tap where they are going to take the sample of the CSF from your back, putting a needle in, and the essential blood work to make sure they don't have any electrolyte abnormalities like low sodium, abnormality in calcium, liver function is fine, kidney function is fine. So those sort of things they're going to be expecting. And EEG is a test which is just to check the brain electrical activity of the brain, and it could be normal and it could be abnormal. Okay, and now this person, should he be started or she be started on seizure medication immediately, or at the time of discharge, or maybe it'll depend on what we found in the investigation. But if everything is normal, there is no cause of seizure, then
So if everything is normal when we do the brain imaging, the lab work, and the EEG is normal, then you're probably going to want to wait if this is a one-time seizure, because the chances that you're going to have another seizure are 50%.
50%?
Yeah, but the chances that you're not going to have another seizure are also 50%.
Oh, right. Yeah.
But if you have any abnormality on any one of those, the brain imaging, if you have an abnormality on any of the labs, if you have a history, for example, that's also a very strong family history, or a history that predisposes you to seizures, then you're going to want to be more cautious. And if you're in the ER, many times what we'll get is a consultation in the ER with one of the neurologists. And the neurologist will come in and weigh all of the factors that we have in and sort of to figure out, is it more risky to put the patient on a medicine, or is it more risky to leave them without the medicine?
And so suppose they decided to be started on medication. How long, when should they see the neurologist or the doctor again? Suppose the patient is started on Dilantin, which is one of the seizure medication, and patient has gone home with Dilantin. Then they should come back to their doctor, like at what time? And then at what time would the doctor say, hey, this Dilantin is not working, let me add another medication or change another medication?
Right. So typically when you're in the ER, your goal is to have no seizures, no further seizures. So you're going to maybe reach for a medicine that you may not want to be on long term. So Dilantin is a great example. You can load that medicine very quickly. It's effective with many of the seizure types that the patients may present with. So it's a great medicine for that purpose. That patient typically gets a follow-up either with their primary physician or a neurologist. A lot of times it will be a neurologist if the neurologist saw them in consult in the ER. And usually it's between, it depends. It's 3 weeks, 2 weeks, sometimes even a week, just to make sure that things are going pretty well. Sometimes if you can't get an EEG in the ER, you'll actually say, you need to see a neurologist to get an EEG and complete this workup. In the meantime, we're going to put you on a medicine because we're not quite sure. And that's an acceptable practice because, like I said, the goal of the ER physician is to make sure this patient doesn't have another seizure, that they remain safe. So at what point do you then figure out if it's working? Typically, you have to observe. If the patient had just one seizure, the next one naturally may have not occurred for another few months. You may, in just a 3-week period of time, you may not know. The important thing to check is that they're not having side effects and that the history is consistent with someone that really should be on a medicine.
Okay. And and the way we assess seizure control will be like, is there an acceptable seizure episodes? Like, okay, in 6 months, only one seizure, again, another episode of seizure happened, so we'll just continue with this medication. Or is it 4 seizure in 6 months, okay, and we can still continue, or no seizure? So the target, I'm assuming, is no seizures.
And you're correct. So good control means no seizures.
Right.
Sometimes we'll have different patient populations that are very devastated by neurological diseases that cause seizures that we know we're not going to control the seizures 100%. But on most patients, that is our goal, no seizures whatsoever, because a seizure, even every 6 months, once a year, can keep you from driving and can be quite devastating for someone's social life, working life, family life.
And I was about to ask you this question now. Suppose somebody is diagnosed with seizure disorder. How long do we wait before the driving privileges are given back to the patient? Because I'm assuming as soon as somebody is having a seizure and diagnosed with a seizure, the driving privileges would have to go away, because it also puts the person at risk for an accident, and also at the same time other people at risk while the affected patient is driving.
Yeah. So different states in the United States varied on their limitation of the privilege to drive, but most have some limitation. Some ranging from 90 days, you have to be seizure-free before you can go back to driving, some up to a year. You need to find out. There's also important differences from one state to the other as to whether or not you have to report your patient to the DMV. Some states do not.
The physician has to
exactly.
report? Oh, wow.
Some states do not require that reporting. They leave that as part of the patient-doctor relationship because it's confidential information. But it's important that you, as a physician, educate yourself as to what are the rules of the state that you practice in regarding reporting the patient to the DMV and when can they go back to driving. So it varies from state to state.
Okay. That's very useful information on driving, because that's one of the most common concerns I have seen with patients. Now, suppose the patient is started on seizure medications, and at times they may need combination medication therapy, and that is if they have another breakthrough seizure, then this physician may put another medication. I want to ask, is it possible for a patient to get off seizure medication if they are seizure-free, for example, for 2 years?
Yes, and that happens actually fairly common. Patients that have a normal MRI, for example, which is our preferred way of imaging the brain, a normal EEG, have history of maybe 1 or 2 seizures, usually 2 seizures because they ended up being on medicine, and have a very, very good control. The whole time that they're on medicine, they have had no other seizures. Usually we, at 2 years, look at the situation and say, okay, so we have done very well. Do we still need to be on these medicines? Oftentimes, then at that point, we get another sleep-deprived EEG and then try and see if we can taper the patient off the medications.
Okay, and then you just want to be carefully watching them because you got,
Correct.
and the medication should not be stopped all of a sudden.
Correct.
You will be tapering the patient over like a few weeks.
Yeah, over a period of time, and it depends on how much medication they're on, how well they tolerate the taper, but typically is a few weeks to a couple of 3 months. So it again is in the patient population where you really found no risk factors for epilepsy, you found nothing concrete on MRI, EEG,
Those are the
and
candidates.
they have done very well on the medicine.
So never stop your seizure medications all of a sudden. Don't let your physician stop it all of a sudden, and you don't stop it all of a sudden. And if all medications have failed, suppose unlike this lucky patient who did not have seizures for 2 years and now we have tapered him off the medication. Suppose there is a patient who we have tried multiple medications. Is there a surgical cure or intervention?
Right. So yes, and so we in neurology like to think of patients as having at least 2 trials of medications. Okay, and if you fail 2 medications.
Oh, 2
and-
medications.
right. So you don't have to be on 13, 15 medications before we say, okay, we have to think of something different. We, in fact, try to educate folks that if you fail 2 medications and you try the medications correctly, meaning that you were on the medications for long enough and high enough doses, and this, of course, doesn't include if you had a reaction to the medicine. That was just a failed trial from that. You really need to think of something else because if you're not controlled at that point, the chances that a 3rd medicine, a 4th medicine, a 5th medicine is going to control your seizures is diminishing exponentially to the point that you get to the point where it's actually almost 0. So trying a new medicine will not help.
And we see these patients all the time on, once I saw a patient on 4 medications, and that's when I was realizing, why are you on 4 medication? We are taking the side effects of the medication without any effect.
Control,
Control,
exactly.
right.
So at that point, that patient needs to be considered for some other intervention that is different from medicines. And typically we think about any type of surgical interventions that could be done, and they typically get evaluated, or we'd like to have them be evaluated, looking at their EEGs, looking at their seizures to try to localize the area of the brain that's active during the seizure to see if we can offer a surgery. Most times when we approach the surgical question, we talk to the patient about the risks, the benefits, and we don't usually go in the conversation thinking that this is going to be a cure, although we hope it to be a cure. We give basically the odds that, with this surgery, at least initially with medicines remaining, your chances of being seizure-free are going to be some X number, and we usually like it to be over 50 before we even consider doing a surgery. In other words, surgeries in the brain are subject to all of the risks that you see with surgeries elsewhere, and then some. We have bleeding, infection, and then we have a risk of stroke as well.
So it carries major complication in itself.
Exactly. So we need to do it, cognizant of the fact that we have to think that it's going to help. and that we can help before we offer it. But definitely, patients that are not well controlled on medicines need to be considered, need to be evaluated.
And that will be the area for neurosurgery. There will be the specialist evaluating along with the seizure specialist.
Correct.
And what is the cure rate? Like, does it help?
Right. So it does depend on the reason for the seizure, the cause of the seizure. Say a lot of patients that have slow-growing tumors that are causing the seizures, they usually do very well. So maybe 80% of them are seizure-free after the surgery.
And I heard, what is vagal nerve stimulation?
Right. So vagal nerve stimulator is another modality to try to control seizures. Now, this is a device that serves almost like a pacemaker to the brain. So a current that actually stimulates the brain over a period of time at certain rates.
Okay.
And so the idea there is that you're going to change the expression of some of these receptors in the brain and overall diminish the capacity for the brain to start seizures. It's not a cure, but it's very effective in 30% of the patients.
So 30% patients respond
See
to
some
vagal nerve
response, yes.
stimulator. And who places them? Is that interventional neurologist or neurosurgeon?
That's usually the neurosurgeons working in
Neurosurgeons.
close contact with the neurologists that are specializing in epilepsy. Yeah.
Okay. All right. Is there a final word you would like to tell our listeners about seizures?
Just to make sure that if you have a seizure or know someone that has a seizure disorder, that you make sure that they are getting the proper care. People with seizures can live very productive, very full lives, but they do need to be under the care of a physician and follow the recommendations of that physician. One of the things that we worry about is medication noncompliance. And so patients, like with everything, you know, if you forget to take your medicines, you tend to have more seizures, and that's a problem. Because over time, seizures uncontrolled generate all sorts of problems, cognitively, socially, and it's
Injury risk.
Exactly, exactly, injury risk. So please make sure that if someone has a seizure disorder, that they're getting proper care.
And is there a very authentic and accurate website we can direct our listeners to if they have more questions about seizures?
The Epilepsy Society in the U.S. has excellent resources that you can avail yourself, from physicians to reading to groups, support groups that you can participate in. So it's probably the best source for information.
Epilepsy Society.
The National Epilepsy Society, yeah.
National Epilepsy Society. Thank you so much, Dr. Sam, for your time.
You're welcome. Thank you.